I'm Curtis Akerman. I'm an optometrist and a developmental optometrist. I practice vision therapy and sports vision. I work with children of all ages and abilities and adults, special needs and your typical children. Where we differ from a normal optometrist is we get more into how the eyes work together to try to maximize visual performance, eliminate any inefficiencies in the visual system that can contribute to learning delays in school. We have a very technologically advanced office. We use digital eye tracking to evaluate how the eyes work together, look for inefficiencies. There's a reading analyzer in the program. So we work with children of all kinds of disability, whether Down syndrome, Usher's syndrome, attention deficit disorder is one of the big ones, and pervasive development delays. So my daughter is a special needs kid. She was born at 26 weeks, had prematurity, had 2 strokes when she was born that resulted in cerebral palsy and developmental delays. Also, she's on the spectrum, so we work with everything, spectrum children. All those kids tend to have visual involvement in their condition. So we have to custom tailor, whether it's somebody like a Down syndrome kid where they tend to have higher prescriptions that can go undetected because they're not reporting the vision deficit, to some kids being diagnosed with ADHD when actually there's a vision disorder that's preventing them from focusing on their tasks. So it leads them to focus on other things. So we want to make sure that we're eliminating all the potential sensory input conditions for those kids to get them functioning as well as possible. Ideally, we recommend that children are examined for the first time at 6 months of age. At that point, they're obviously not reading. We're going to put some drops in their eyes to check for gross prescriptions, any health issues or binocular dysfunction where their eyes aren't working together, anything that's going to impede their development through that critical developmental stage as they get ready to go into school. After that, we examine them every year and we look for normal milestones. We want to watch that they're not developing myopia, which is nearsightedness. The earlier we catch that, the better we can be at controlling how far the myopia progresses so that they don't become extremely nearsighted as they get older. We want to make sure that some of the kids that'll slip through, like kids with hyperopia, which is farsightedness, which means that they have to focus harder to see everything. So they can still see far away and close up, but they're working extra hard all the time. So we want to help those children to see better so that they're able to function without extra effort. There are a lot of hidden conditions that won't be noticed, won't be picked up at home, like convergence insufficiency, where when a child is reading, their eyes don't converge onto the paper. That leads to skipping words, missing sentences, rereading paragraphs. And it doesn't just stop as a child, that'll carry right into adulthood. So I have convergence insufficiency myself. I didn't know until optometry school that it wasn't normal to reread paragraphs, to lose your place all the time. I thought that was the way people normally read. So a lot of times kids can overcome their visual deficiencies, but it takes a lot of work, and a lot of those kids aren't going to be lucky enough to overcome them. So we want to pick those up as early as we can to give them the best chance to have success. Another area that we work with is dyslexia. So not only do we work on how people see, but how they process what they're seeing. So we can do visual perceptual evaluations. We do therapy to help remediate inefficiencies in the way the brain processes information. So we start with making sure that the information that gets to the brain is good, and then we make sure that the way the information is processed by the brain is good, so that we can have a good output. Dyslexic people, or people who've been diagnosed with dyslexia, sometimes it's a visual inefficiency that's preventing them from seeing properly, where with either a little vision therapy or sometimes even something as simple as glasses for reading, they can function much better. Last month I had a 10-year-old girl. She came in really struggling in school. She was having remedial reading help. We did an examination. We realized that she was hyperopic, farsighted. We gave her some glasses that let her relax her focusing at near and still see the board in distance. And a month later, she was ahead of grade level for reading. So sometimes something very simple like that can really make a big difference in somebody's life, where the parents might not have even thought that it could be a vision issue that's causing the problem. So when we detect inefficiencies in the visual system, if the eyes aren't tracking together, or sometimes if the efficiency in reading isn't proper, we can train those eye movements. In our clinic, we use a combination of traditional vision therapy, tracing, following moving objects, in addition to virtual reality training. So we use a lot of high tech in the office to keep the kids engaged. So they get to play games while stimulating their vision. Traditionally, amblyopia, which is a lazy eye where one eye doesn't learn to see as well as the other one, we used to think that the recovery of amblyopia was capped at about age 7 or sometimes up to puberty. And what we've realized is that if we train it properly, using some of these virtual reality conditions where we can trick the brain into thinking that the eyes are open, we can trick the brain into using the amblyopic eye and actually develop better vision and better depth perception to help people function better in their daily lives, even up to into adulthood. So we incorporate that, and then we also incorporate some of our sports vision training into our vision therapy depending on what the patient's needs are. So if we have somebody who's uncoordinated or having trouble, sometimes it'll be that kid that goes to put a cup on the counter and misses the counter half the time, or the clumsy kid who's always the one knocking over the milk pitcher at dinner time. A lot of times those are depth perception or spatial perception issues. So we can train that not only to improve their athletics, but to improve their quality of life. We incorporate the sports vision training into some of the vision therapy patients' routine to help them just enjoy it more and get more out of life. Our sports vision training specifically, we use our digital eye tracker. It has a sports vision analyzer, so it analyzes how the eyes are working together compared to other kids at the same age, the same level, the same sport, and the same position. We also have a computerized touchscreen television. It's about a 60-inch TV, and it runs 10 metrics on visual performance. So it looks at how clear your vision is, how well you see in low contrast, what your reaction time is, your hand-eye coordination, your processing speed, how many things you're able to pay attention to at once, how well you track multiple objects in space. It analyzes all those things, again, against age and sport and position level norms. And it gives us a really good evaluation of where a kid would fall into their age group and category. Are they at age appropriate levels? And then it allows us to train not only up to normal, but up to levels of excellence so that we can increase performance. We've trained professional goalies, junior hockey players, volleyball players, tennis players, so it translates to really all sports. So we also have an optical where we sell glasses. We have special glasses designed for children that are unbreakable. The demo video shows a kid smashing them with a hammer and they bounce back. We don't recommend that, but it can be done. Our goal with our patients is to make sure that they're able to function at their highest capability. And that might mean higher than what we thought it was. So we always reevaluate our patients as we go. If we see that they're exceeding our initial expectations, then we reset our goals and try to raise them and get the kids functioning as well as possible so they can integrate into school and into society at their maximum level.